I am Temke from Sanapi, and together with me, my colleague Rita. We are excited about today's webinar. For today, we are focusing on the first E, emotive, early blood detection. And we have the privilege of being joined by Dr. Hadiza Galadanci, all the way from Nigeria. So she is a professor of obstetrics in gynecology and trained and mentored over 600 medical students, residents, and postgraduate students. She's a consultant to many development partners, including WHO, USA, UNICEF, UNFPA, MNCH2, and I'm sure even the list goes on. And then she's also an award-winning obstetrics and gynecology doctor. She got the FIGO Women Award in 2018 for leading work in Nigeria on maternal health. And this is really just a tiny bit of all the great things that Professor Galadanci have achieved. And like I said, this is a small list. Her achievements is much greater than this, but I'm going to give over to her because that's the real reason you are here today, is to hear from the expert talking. So Professor Hadiza Galadanci, the floor is yours.
Thank you very much, Temke and Rita. So thank you, and I want to thank Sinapi for inviting me to make this presentation. And my topic is, the emotive trial, and then specifically looking at the E aspect of the emotive, and therefore the DRIP. The outline of my presentation will start with just reminding us of the scale of the problem of postpartum hemorrhage. And why is it that it continues to be a problem despite, all the interventions that we have to address it? And then specifically looking at the three reasons as the missed or the delayed diagnosis of postpartum hemorrhage, and we'll also look at the missed or delayed treatment of PPH and the missed or delayed escalation of refractory PPH. And then we'll just explain the whole concept of the emotive. And then I will tell you briefly the results. And then, of course, what do we do after having this result of the trial? Most of you, or all, I think all of you, are healthcare providers. So I don't need to really emphasize that much of the burden of maternal mortality, especially in sub-Saharan Africa. Right now, almost 70% of all maternal deaths occur in sub-Saharan data. And unfortunately, so we carry the brunt of postpartum hemorrhage, but I mean, maternal mortality first, but at the same time, also postpartum hemorrhage. And we know that postpartum hemorrhage contributes almost a definition of postpartum hemorrhage, that it's the blood loss of at least 500 mils or more within 24 hours of birth. That is primary PPH, and we know that there is secondary PPH, and we know this is just one of the definitions. You can also look at the clinical state of the patient to also make a diagnosis of postpartum hemorrhage. The estimate is that there are about 14 million people, women, that actually develop PPH every year, 14 million. And out of this 14 million, 99% occur in low and middle income countries. And out of them, we'll have almost half a quarter of, 500,000, that's 500,000 women that died with PPH between 2003 and to 2009. And when they say out of this 14 million people, about 70,000 women die from postpartum hemorrhage yearly. Now, we also know there is postpartum hemorrhage arising from cesarean section, but this 40 million is those for spontaneous birth as well as cesarean section. But 70,000 would die from PPH arising from spontaneous birth. But it's not only the maternal death that is a problem, but the morbidity that those that survive the death, you have morbidity because they might end up with surgery, with hysterectomy, with pelvic pain, with blood transfusion and all the complications of blood transfusion, probably with the renal failure, with all the complications of renal, the renal organ, as well as even the children that they leave, the family that they leave behind, because they say that 3 out of the 4 babies that are born from a woman that gets PPH actually that dies, then they also die within 6 months of the mother dying. Even when they are not really matured enough to do that, and they'll probably miss out of education. And we know that the death of a woman goes beyond just the death. There's so much in terms of economic, social, social problems that arise from the death of the woman. So this is the extent of the problem of postpartum hemorrhage, and therefore we all of us have been trying to see how do we actually address the problem of PPH, and a lot of interventions have been identified for many years on how you can address or how you can prevent PPH. The basic thing of the management of the third stage of labor. We all know that is why we do third stage of labor, so that we can prevent PPH, the active management, and every single person that is managing labor, knows how to do the active management of third stage, so that he will, prevent the likelihood of that woman getting postpartum hemorrhage. But it still continues to be a problem. Despite all this, people still die from postpartum hemorrhage. So what are the reasons? And, from the literature and from experience and from everything, we realize that, for the emotive trial, we realize that, there are 3 major reasons why PPH continues to be a problem. The first one is that we miss the diagnosis of PPH. At times we miss it completely, and at times we delay it. Therefore, if a woman starts bleeding, before we make a diagnosis of PPH, we take so long, because how do we estimate that a woman has lost 500 mils? You can see the definition is 500 mils. So how will you know that a woman has lost up to 500 mils? All of us know. If I was going to ask you, if I was in an open a lecture where I'm facing the participants, I'm going to ask you, how do you estimate it? First of all, it's an estimate. Everybody knows it's an estimate. Secondly, you only estimate it looking at the blood on the woman, on her cloth, on the floor, the part she has used, the one in the bin, everything. That's how you will estimate, and you use your head to just estimate. Now, over and over, we found out that this estimation is really, really, really wrong. And I'm going to show you why I say so. Then the other thing is that when you now even diagnose or say, okay, this is PPH, because the woman has started saying, I can't see, I need water, she starts sweating, she starts being irritable, then you realize that, oh no, this woman has lost a lot of blood. You look around and you see, oh no, the blood on you, even on your own Macintosh, on your own hands, on everything, the blood is just too much, and there's blood on the floor. Then you start treatment. Now that treatment, there's so many options of treatment you can give. And unfortunately, we give one after the other. So we give one and wait and wait and wait and wait and see whether that one will work. Then if it doesn't work after 30 minutes, we go to the next one and we wait to see what the second one will work. After 30 minutes, we do another one. So by the time you give her all the treatment she requires, it's about 1 hour, 2 hours. And at that time, the system has just stopped acting the way it's supposed to act, and she's just bleeding away. And then that's when you realize that you probably even need to escalate. So that is the second delay that we have identified. Then the third delay is that, even when you now think she has lost so much blood. Before we give her the final treatment in escalation, we also waste a lot of time. So let's start with the first one, which is that misdiagnosis. So as we said, we actually do a visual estimation, and visual estimation is really, really not optimal. And you can try it in your hospital. Just get blood, know the quantity of that blood, put it in a container, pour it on a cloth, and tell 10 healthcare workers to estimate the blood that you think is either in the container or on the cloth. You will be amazed at the range of figures you're going to be having. So for almost 2,000 people, in fact, in five countries, you're talking about almost 5,000 people or 6,000 people that we trained for the emotive. We put these different quantities of blood, which is just, of course, it looks like blood, and we label it ABC, and we tell healthcare providers that we're going to train that they should estimate the amount of blood in each of this container, either the container with a cloth that is soaked with blood, or in a kidney dish, or a blood plus a cloth. And the first one, like the A, which is the actual blood is 600. We had people estimating as low as 200 to as high as 2,000. All right. B, which I think the amount of blood is 200. We had people estimating as low as 100 and as high as 500. In C, that is 300. We had people estimating as low as 200 and as high as 1,000. And then you had people D, which was 500. You had people estimating as low as 200 and as high as, I think, 1,000. So you can see the range. You can see the range. So what we say is that visual estimation is equivalent to blind estimation, because really there is nothing for you to actually make a tentative good estimation. And then apart from that, we also have data, which is the champion data. The champion data was a study that was done, which was a multi-country study that was done looking at heat stable capacity. And we showed in this data that up till only 26% of women, which means almost 75% of women, do not receive any uterotonic drug when the blood loss is up to 500 ml. So it means that that healthcare worker that is taking care of that patient has not realized that the patient has PPH, because she would have given uterotonic. Because we know that everybody knows once a woman is bleeding, after you've done your third stage of labor and she continues to bleed, you give oxytocin. That's the first treatment. But because you have not made the diagnosis, you haven't even given it. Because you haven't made the diagnosis, there is no way you can give any uterotonic. So you can see that 75% of women that are supposed to get that uterotonic, because they have already lost 500 ml, they did not get it. Only 26% got it. Now that is even just 500 ml. When you go further and you go to 1,000 ml, which is severe PPH, up to 30% of women did not receive treatment, which means even up to that 1,000, 30% of the women were not diagnosed to have PPH. Now, you don't need anything else to tell you that visual estimation is really not working, and that we're really missing the diagnosis or delaying the diagnosis until the woman has lost so much blood. Even at 1,000 ml, that's severe PPH. She's lost 1 out of 5 of her whole blood level, but she hasn't been given treatment because somebody has not realized that she's bleeding. All right. So now, how do we improve this estimation? How do we improve the diagnosis? How do we now say, yes, this is, we can diagnose PPH when we're supposed to. And there has been a lot of, a lot of different interventions, all right, that has been tried a long time ago, not even now. We use, the kidney dish, the calibrated kidney dish to try to, scoop the blood. But there's blood on the cloth. So that is something else, even if you scoop the blood. So you have containers. Some people have used what you call the Calis pad and the basin, right? Some people have used standardized cloth. They use a cloth, they know how much it is when the cloth is soaked. But the soaking of the blood can be of different, different amount of blood. So that's another method. Some people have used mats. So many different interventions. But the intervention we use in emotive is the calibrated drip. And I'll be talking about the calibrated drip, right? So what the calibrated drip does is that you put the calibrated drip underneath the buttocks of the woman when she starts labor, but you don't open it up. You close it, you roll it up. When she has delivered and the baby is out, so first stage of labor, LICOR has gone, baby is out. You now release the end of the drip, which will hang, and then you now start, collecting the blood that she's losing. And we calibrated it so that you can actually see how much is 200, 300, 400, 500, and 1,000 and above. So that is for the misdiagnosis. Then we have for the delayed treatment. So if we miss or delay treatment, how do we now improve that? And to do that, the usual care is that you do what we call sequential treatment, which means we know that massage, all of us as healthcare workers, whether we're nurses or we're doctors, the first thing you do when a woman is bleeding is to massage the uterus, because it's uterine atony that is the commonest cause. 70% of bleeding will be as a result of uterine atony. So you rub up contraction, massaging the uterus. And then you think that will work. And then you wait and see, okay, the uterus is well contracted, she stops bleeding, and you go ahead and continue doing your work. And then by the time you come back, the uterus has gone to 30-week size, and then she's accumulating blood inside the uterus. Then you say, oh no, okay, let's give oxytocin drug. You give oxytocin or you give whichever oxytocin drug you have. And then you think the oxytocin drug is going to work. And then you give another 10, 15, 20 minutes, then you come back and then she's still breathing. Then you remember that there is tranexamic acid that have been said to also work. Then you give tranexamic acid. So all along you're delaying and delaying and delaying. So what we did in emotive was to give a bundle approach, which is the motive bundle. So M is for massage, O is for oxytocin drugs, T is for tranexamic acid, IV, and then IV, tranexamic is T, IV is IV infusion with drugs inside, and then E is the examination and escalation. So this is what the motive bundle is all about. So what we're saying for emotive is that for the PPH diagnosis that we delay, we do early and accurate diagnosis with our E, which is the E for the emotive. For the first response treatment, which addresses the delay in treatment, we give the bundle treatment, which is the motive without the E. And then for the E, for the escalation, we do we do the rapid escalation, which means you go, you examine, and you escalate as appropriate. So this is what emotive is all about. So in terms of, the important message in emotive is that it does not bring a new PPH intervention. There is no new drug. There is no new procedure. So it's the same thing we've been doing, but it is a different approach. All right? It is a different approach. All the interventions, whether it's massage, whether it's oxytocin, whether it's tranexamic acid, whether IV fluids with oxytocin, whether examination, whether escalation, these are all proven interventions that have been there for ages. And every healthcare provider that takes care of pregnancy knows about this intervention. So we are not bringing anything new. What we are doing is that it is a new approach. A new approach, instead of us delaying treatment, instead of us delaying diagnosis or delaying escalation. Now we are doing rapid, accurate diagnosis and then given the bundle up. Now, what is a bundle approach? What is a bundle treatment? So a clinical bundle is just a set of interventions that when you perform them for a specific condition, they've been proven to improve the patient outcome. And you give the interventions at the same time. All right? So all the components of a bundle are given within the shortest possible time without waiting to see whether one of the intervention is going to, the patient is going to respond to one of the interventions or individual interventions. So we give them, even if when you do the first intervention, there is a response, continue until you give the second, the third, and the fourth intervention. So you give them at the shortest possible time. And for us in Emotive, we say within 15 minutes, you give every single, you give all the intervention. So in terms of the E, just a bit of more, I will talk about all the different aspects a bit more. What do we do now? So what we do now is visual estimation, all right? And then probably we'll also record it's always when the woman starts saying she's feeling dizzy or wants water, then we try to check her blood, her vital signs, and we realize that her blood pressure is going low, her pulse is going high. And then we just make a clinical diagnosis and judgment. What we are saying now is that we use a drip, all right, which is a calibrated drip. The yellow line is at 300 or 350. For Nigeria, we use 300 as our warning line. And warning line means that once the patient gets to that warning line, that means you can see blood up to the yellow level. And she has either her pulse is high, her blood pressure is going low, or you can see blood still coming out, then you trigger the bundle. That's what we say, you trigger the bundle. All right, you don't even wait until it's 500 mils. Because between 300 and 500 mils is so fast that really, when patient has lost up to 300 mils, there is no reason why she would not lose up to 500 mils. So we just start, all right? But for some other countries, we had the trial in 4 countries, Nigeria, Kenya, South Africa, and Tanzania, all right? So because some countries decided they will want to wait until it is that 500 mils. 500 mils is the red line. So at 500 mils, as soon as a woman gets to 500 mils, automatically you trigger the bundle, all right? And then you keep on monitoring both the blood loss as well as her pulse and her blood pressure. You monitor the blood loss monitoring chart. We have the monitoring chart. You go every 15 minutes, you look and see now it has gone to 350, 508, and so on, and you monitor it, and you also check the blood pressure and the pulse. So this is a calibrated drip, all right, with the yellow line, which shows the warning sign, and the action line, which is the red line. And you can, as a healthcare worker that is so busy, you already have the drip. By the time you just go elsewhere in the labor ward and you look back, looking at the drip, and you see that the blood is still coming in the drip, you quickly come back to her. You don't have to go and check and estimate how much blood she has lost that is on the floor. So now what we do, as you can see, this is the chart that we use. So 500 mils on the blood, it's a diagnosis. And then 300 mils from any other observation. All right, 300 mils and any other observation, we also make the diagnosis and we start treatment. And you can see how the drip is used to measure the blood loss. all right? So all the interventions in the bundle, which means our motive, supposed to be given within 15 minutes, shortest possible time. And all the bundle interventions should be given regardless of any improvement after any intervention. So if you're alone and you have to give all the interventions, then you do them quickly. And that is why we have what we call the PPH trolley, all right? On the PPH trolley, we have all the things that are required to give the bundle, which means on that trolley, you have your oxytocin, you have all your oxytocics, whether you use only oxytocin or you use heat-stable carbetocin or you use misoprostol, you have it all on the table. You also have your cannula, you also have your given set, you also have your swab, you also have your tourniquet, you also have your tranexamic acid, you also have your IV fluid, you have your non-pneumatic anti-shock garment in case you're going to escalate, all right? You have your blood, the blood sample in case you're going to do PCV, U&E, so that you can take patient to the theater. So everything is on the trolley. So once the patient starts bleeding, you just wheel the trolley to the side of the patient and you have everything that you can use. Now, if you don't do that, like for example, where I treat, is when you now want to give oxytocin, you now remember you have to go and get a syringe somewhere. And then when you have finished with that, you remember you need a tranexamic acid, and there is no tranexamic acid in labor ward. You have to go to the pharmacy to collect tranexamic acid. Then when you come back, you realize that the given set is not available. You have to go to the matron's office to get a given set. So you can see you're wasting time and a woman is bleeding away. All right. So, but when you have this all on a trolley, then it is so simple for you to give all the interventions within 15 minutes. Of course, if you have the privilege of having more staff in the labor ward, then you should ask for help. And that's the first thing we teach medical students when you're managing PPH. You can't do it alone, you need help, so you call for help so that others will help you as you're doing all the interventions. The massage, we know, unfortunately, in the literature, there is nothing that really defines what a massage is, but every healthcare worker knows what a massage is. So you should be massaging the uterus until it is well contracted, and you should be checking. In fact, and please talk to your patients when you are massaging because it's very painful, and she can even be doing it when you're doing other things. She can be rubbing the uterus so that it will stay contracted, and she can tell you if she feels that the uterus is getting relaxed, all right? Then you give oxytocin, and the oxytocin you give, what we say is that you give 10 to 40 international. What we do now, and we have asked from the, from the healthcare workers before we started. Some will say they give 10 international, some give 20, some give 30, some give 40, especially in our environment when the oxytocin is not optimum because of storage. You know that oxytocin is supposed to be kept at 2 to 4 degrees. So a lot of the oxytocin that gets to us in low middle income countries where even power is an issue, they are not optimum. And we have even done a trial. We've tested all the oxytocins that we had for the trial, which means all the 80 sites across the 4 countries, we tested the oxytocin that is in their facility. And we found out in Nigeria that there were only 2 oxytocin that were good out of 14 brands that we had in our 40 facilities. So that's what we give normally. But what we are saying now is that you give 10 international units of quality oxytocin, and you can give it a push or you put it into just 500 mils and give it over 10 minutes. So you either give 10 international units for 10 minutes or inside 500 mils for 10 minutes, all right? And then you can give 20 international units in a liter that will run for 4 hours, all right? Which is the IV of the motive bundle. And then for us, we use misoprostol as well because our oxytocin is not optimal. So some give misoprostol sublingual, some give misoprostol rectally. Now, as I said, we need to remind ourselves that actually, you know, oxytocin is supposed to be kept 2 to 8 degrees, and we know that we have problems of refrigerator, of cold chain, of power. So most of our oxytocin in low middle income countries really have the problem of storage, and therefore the problem of being optimal. The T is the tranexamic acid. We know the woman trial that has showed that giving 1 gram of IV tranexamic acid slowly over 10 minutes can actually reduce a third of maternal death from PPH. So it's also advocated, or that is part of now emotive. So you give, even after your oxytocin, after your IV, you now give IV tranexamic acid slowly, and it has been shown not to have any protocol or any problems, and midwives can give IV tranexamic acid, because for us, like in Nigeria, we have a policy of tax shifting, and therefore the nurses and the midwives are allowed to give IV drugs. As I said, the IV is you put 1 liter of crystalloid, you put 20 international units, and it runs over 4 hours. If you ask people what they do now, it is a lot. People do different things. Some put 10, some put 20, some put 40, you know, international units in a liter, some put in 500, some run for 1 hour, some run for 3 hours, some run for 6 hours. So now we have standardized. Then the E, of course, is the, you know, check, examine, you check the bladder, you check the perineum, you check the placenta, all right? The bladder, you empty the bladder, you check the placenta to make sure it's complete, and you check the perineum to see whether there is any laceration. And if there is any laceration, either starting from the laceration from the perineum to the vagina, to the cervix, or even to the uterus, you now have to repair. And then, of course, think of the other causes of PPH. You know, we have the T for tone, we have the T for trauma, we have T for tissue, and then T for tone, trauma, tissue, and what's the last T? Tone is uterine, of course, the uterine tone. Then the placenta, retain fragments of the placenta. Then trauma, which is the laceration, and then tissue, which is the coagulation. Because when a woman has bled so much, then she will end up with the DIC. So escalation, of course, escalation is that when the bleeding continues, despite all this, then you need to escalate. You either transfer, and when you're transferring, we recommend that you use the non-pneumatic artificial garment, because then the woman will get to the facility alive, so that they can now give her definitive treatment. If it's within the hospital, then you might need to take her to the theater. You might need to you know, start either laparotomy, or you might need, if it's a cervical tear, you now have to manage it. And of course, you can do B-Lynch, you can do subtotal hysterectomy, and all the other interventions that are there to manage refractory PPE. Now, so for you to implement the emotive, there are 4 things that have to be done. One is that you must have the trolley, which I've discussed. Then training, you have to continue to train healthcare workers, because it's only through training that your healthcare workers will be able to learn this new approach. As we said, it's just a new approach. Then you need champions. Champions are people that will continue, you know, to support and advocate for that new change. And then, of course, you need audit and feedback, because people want to know what they have done, whether it is working or not. Now, we have published this you know, trial in the New England Journal of Medicine, and it's important to mention that this trial is, you know, the collaboration of many centers across the globe. So we have our central team in Birmingham University, UK. We have team in South Africa, there in your country. We have team in Tanzania. We have team in Kenya, and we have a team in Nigeria. So it's the effort of so many people across these 4 countries that have brought us to where we are. So we had 80 hospitals across the 4 countries, Nigeria, Kenya, Tanzania, South Africa. And we used hospitals that had between 1,000 and 5,000 deliveries. And we had almost about 200 and we had 220 something thousand deliveries across the 4 countries. I'm just going to mention, the results, just the final result, which in the intervention, out of these 80 facilities, 40 were intervention, 40 were control. So 40 were trained to do emotive intervention, and 40 continued to do the usual care that they were doing. And in the emotive, that is in the centers, in the 40 health facilities that were trained, the severe PPH, which is our primary outcome, severe PPH, laparotomy, or maternal mortality as a composite outcome, we had 794 women that had severe PPH out of 48,000, deliveries. In the usual care, they had 2,139 out of about 50,000 deliveries. That is a risk ratio of 0.4, which shows that there is a 60% reduction of severe PPH in the intervention as compared to the control. Now, this is the results that really showed, the impact of this emotive intervention. And I'm happy to say that based on this, okay, the other thing is that, of course, in terms of, detection, in the emotive facilities, they detected PPH 93% of the time, while in the usual care, only 50%, which means 50% of the women that had PPH were not detected. They weren't given oxytocin, while in the emotive, we detected 93% of the time. And for compliance with the motive, of course, those that were trained, we had 91% compliance. And those that were using the usual care, only 19% of them said, oh no, this woman is bleeding, let's give her all the interventions that we know. All right? Now, this really shows that, emotive is really an intervention that will save our women from getting severe PPH and therefore dying from PPH or having severe morbidity. And with this result, and the presentations that were made and the publication, WHO has actually, updated its guidelines. So there's a new PPH guideline. If you haven't seen it, Google it and you're going to see it. It was launched on 23rd of December, 2023. So now WHO is saying that you should do early diagnosis. And of course, what we do is using the drip. But what we want is early diagnosis. And when you do early diagnosis, then give the bundle treatment. That is what WHO is saying. And it's basically based on this result as well as other results that have been out even before this. So ladies and gentlemen, early detection and treatment of postpartum hemorrhage using the WHO motive bundle, first response bundle, is the answer to reducing the thousands of women that die from excessive bleeding. And I hope that I've been able to convince you that you have to do early diagnosis using a drip, and you have to do the motive treatment to save the woman from dying. Thank you very much.
Thank you so much, Prof. Hadiza. We really appreciate your time and effort for doing this presentation. I just want to say thank you. It was very eye-opening. I must say to everyone here, good news is that SANAPI was actually approached by the Bill Gates Foundation to actually develop a drape for this early detection. So if you guys want any information or would like to contact us on buying the drape, please feel free to contact us at SANAPI, or you can contact me directly, which is Rita D at Sanapi Biomedical. Again.
All right. Thank you very much, Professor Hadiza, again for coming and sharing your knowledge and your expertise on this subject matter. And a big thanks to everyone who have taken out the time today in their busy schedules on Valentine's Day, maybe giving up a lunch date or an early breakfast date to enjoy and to learn from this webinar. We are out of time for today. If you do have any other questions, please do reach out and we will then attend to those questions when we do receive them. But I think it's important to remember today that what the emotive has shown us, the success of it is that it is to be used as a bundle, and all parts of the emotive bundle is important. That includes the first E, early blood detection, in order to be able to intervene quicker. So then using something like the drape, and then as my colleague mentioned, that Sanapi Biomedical manufactures and supplies, and then also everything in between all the way down to the very last E of escalation, which will be our focus for next week, the last E of emotive escalation, and we will have Dr. Sam Ononge from Uganda talking a little bit more on that. And we can say we have already said in this webinar that we can insert and refer using the LRV UBT, and Dr. Sam Ononge will be sharing a little bit more on escalation next week, Wednesday, the same time. But for today, we are done and we are saying goodbye. Again, big thanks to Professor Hadiza and everyone else for joining us. We'll see you next week.